All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. It helps, these exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, my name is Dr. Heegaard. You are listening to the GynoCast. I'm here with my buddy, my boss, my co-wingman woman, Twila Dang.
Hi.
Today we're talking about polycystic ovarian syndrome.
I like it. Tell me more. See, you thought I was going to be like, okay, come on.
That was 5 seconds, Twila. That was less than 5 seconds.
So here we are talking about how the sausage gets made again. I challenged somebody in this room to get to the topic faster, and he literally took a breath and just jumped in, which he thinks I have a problem with. I do not.
So I'm in now.
Okay,
I'm number 1.
For today.
No, I'm talking about
number
today.
1.
For today.
For today.
We got to the topic in 5 seconds.
Yes, you did.
So, Twila was saying that I end up talking a little bit too much about other stuff before getting to the topic.
Which he's doing now.
But this is the great thing, is I got to the topic, and now I can drift around, right?
No, you still need to talk.
All right, so for those of you who are new to the GynoCast, welcome. And for those who are recurrent listeners, we love you just as much, just differently. And so what is polycystic ovarian syndrome, Twila?
It's a medical condition.
It is a medical condition.
Yes.
This is one of these subjects that people just, it's not a term that people just sort of banter around. Like, people know, if everybody says cancer, people have an idea in their head about cancer or a heart attack or stroke. People know about this.
Absolutely.
Polycystic ovarian syndrome is something that is not one of those topics that people really have heard that much about, but it's incredibly important, especially in women's health, because somewhere between 10, it just kind of varies in the studies, but around 10, maybe even 15% of women fall on the spectrum of having polycystic ovarian syndrome. That's a big deal. And 11% of women in their lifetime will get breast cancer. Well, I'm saying that polycystic ovarian syndrome affects a lot of women as much or even more than that. And so why do we care? Well, there's a couple different reasons. One is that there's cosmetic issues, but more importantly, there are medical issues that can lead to, long-term medical problems and that can affect you in your whole life. Mm-hmm. So the polycystic ovarian syndrome is a condition which results in a very subtle hormonal imbalance, especially at the level of the ovaries. Now, the ovaries have this delicate balance of estrogen and progesterone and testosterone, so the whole system works right. And in polycystic ovarian syndrome, there is an imbalance, an excess of testosterone or testosterone cousins called androgens. And the ovaries do not work well in a testosterone or androgen-rich environment. Mm-hmm. And so because of this, they don't release an egg on a regular basis. This is the most common symptom, and it causes irregular bleeding. And so, again, why do we care about this? Well, it is probably the most likely reason why women have abnormal bleeding during their reproductive years. And so we are talking about, in the United States, we're talking about millions of women are on the spectrum, and they don't know about it. Most of them don't know about it.
Is it misdiagnosed often, or is it just that it's not even something that comes up in the sort of thought process if you're going through, like, sort of a health audit?
Yeah, it's something that is not thought about either by the patient oftentimes or their practitioners. because a lot of times it won't cause symptoms that are that, at least initially, it will not cause symptoms that cause a lot of irritation or bother.
Okay.
And, a lot of women will say,
So it's
well,
like inconvenient, but it's not like painful or...
Precisely.
Okay.
Precisely. So let me just say, what are the most common symptoms? The most common symptom of all is abnormal bleeding. And by that I mean, usually it means the woman does not have periods as frequently as she should. Now, what is the normal interval between one period and another? Around 25 to 35 days. So between 3 and 4 weeks between the beginning of one period and another is normal.
Mm-hmm.
And so women with polycystic ovarian syndrome oftentimes will have periods every 40 days or every 50 days or every 4 months or in more severe cases every 6 months and sometimes never or hardly ever. And so, a lot of women think, hey, this is great. I never have a period. But as we talked about on the GynoCast and on live radio, it's important to have a regular period to have a healthy uterus.
Mm-hmm.
And so the most common symptom is some sort of irregularity in terms of how often a woman has her period. And we're going to go back in a bit to talk about why that matters. But that's number one. The other thing it can cause is issues with infertility, because if you don't release an egg on a regular basis, you can have trouble getting pregnant.
Uh-huh.
It also can cause some physical or cosmetic issues in the sense that the elevated levels of testosterone can sometimes cause abnormal hair growth and acne. And so these are some of the things that we are looking for.
Now, I have a question, because the few times I think I've seen sort of PCOS referred to like in television format, like when you see people sort of cataloging their journey, you see the two most primary things I tend to see are the emphasis on the abnormal hair growth, like seeing women that traditionally like wouldn't have a beard but have like more fuller facial hair, like almost having a full beard or possibly a full beard. But also a lot of women that I see with what they consider excess weight gain. Mm-hmm. Is that a pretty common thing?
Yes, it is. And so these are the things that oftentimes will, if women know about it, and if their practitioners or doctors are paying attention, they can ask about whether they have these symptoms. And so, I do a lot of work with infertility as well as pelvic pain. And so, I'm always, especially from the fertility standpoint, I'm always looking out for it. Mm-hmm. And so one of the questions I always ask are, well, tell me about your periods. How often do you have them? And I'm looking to see whether they have their periods at the normal interval. And do you have any abnormal hair growth? Do you have acne? And one of the questions I ask is that do you need to pluck or shave? Because and a lot of.
Isn't that? I mean, because I feel like we all do that. But you mean, do you is it required to shave?
Yes.
Because otherwise it would be very noticeable.
That's right. So This is the thing, that there's a spectrum. And also different ethnicities, people from different parts of the world tend to have darker hair. Like if you're from Norway, perhaps, where everybody's blonde.
Yeah. It might be a little bit more fine.
Yeah, you may have some facial hair, but it may be very light.
Right.
Whereas people from the Mediterranean or other parts of the world, if you have increased hair growth, it may be more obvious. And it's also a difference in the feel of the hair, because we all have soft hair all over our body. Mm-hmm. It's called vellus hair, and so that's there to keep us warm. And so there's a difference between soft hair and what's called terminal hair, which is hair growth related to testosterone. That's what men have. It's coarser. And so women with more severe forms of polycystic ovarian syndrome, and they get 5 o'clock shadows.
Right.
And they can pluck or shave, and you can really see the actual hair follicles where they're coming out. Mm-hmm. And so that doesn't necessarily, if you've got that, it doesn't necessarily mean you've got polycystic ovarian syndrome, but it's one of the things to look for.
Okay.
And so one of the things there are criteria for making the diagnosis. And so I think sometimes if we look at the criteria, that helps sort of fill out more about the condition and understand it. And so there's 3 basic categories of things we look for. And these are based on a criteria called the Rotterdam criteria. Now, I say that just because when you say something like that, you sound like you know what you're doing, right?
Yeah,
and you
indeed.
are just, I can see that you are speechless and you're sort of lean back in your chair like, oh my God, the Rotterdam criteria, right?
Yes.
Yeah. So the Rotterdam criteria looks at 3 different things. And in general, it is thought that if you have 2 out of 3, you meet the criteria of polycystic ovarian syndrome, although it's always a little bit of a moving target. But number 1, ovulatory problems, menstrual irregularities. So if you are having periods that are not happening roughly every month, and this persists for a while, then you can say, chink, that's number 1. You have weird and wacky periods. Number 2, evidence of elevated androgens. And testosterone is under the category of androgens. And those are what we generally consider to be the male-type hormones, although women have them too. And so what are those manifestations? Well, abnormal hair growth on the chin, on the chest, it can go down into the belly, on the abdomen. And it tends to be coarser hair. And women will pluck and shave and that sort of thing. Other manifestation could be acne. And so, it's always a little hard because especially in teenagers, most of them have acne. But especially in adults as they get beyond adolescence, if they start having acne, you just got to kind of pay attention to it as a possibility. Now, those are clinical manifestations. Those are what we see on the outside of the body.
Mm-hmm.
Also, you can also use criteria from laboratory evaluations. So oftentimes what we will do is we will check blood tests including testosterone, free and total testosterone, DHEAS, which is a androgen that is produced by the adrenal glands as well as the ovaries. We will also oftentimes check a cholesterol. We'll check an insulin level, a glucose level, and luteinizing hormone and follicle-stimulating hormone. These are some of the basic ones. But for making the criteria of polycystic ovarian syndrome from the Rotterdam criteria, you can either have skin manifestations like acne or hair growth, and you could have something that's cropping up in the laboratory results, meaning elevated testosterone or DHEAS. Mm-hmm. So that's number 2. So the first one was abnormal periods. Second one was elevated levels either clinically or from a laboratory standpoint of elevated testosterone. Number 3 is cystic ovaries. So there's actually on ultrasound a particular appearance of the ovaries that we actually call polycystic appearance. And these ovaries have kind of what is called a ring of pearls effect. So on the very periphery of the ovary, you see these little dots, and that's a PCOS effect. And so in general, we say if you have 2 out of 3, you meet the criteria. And so you conceivably could have fairly regular periods, but if you had acne or hair growth or elevated testosterone or DHEAS from a laboratory standpoint, and on ultrasound you had these findings, you meet the criteria of PCOS. And so, again, why does it matter? And part of it is that it requires looking for it so that you can identify it, so you can educate your patient.
Yeah, absolutely.
Because again, people are more concerned about the cosmetic effects, but beyond that, it actually can have some significant health implications. And so that goes back to what is the underlying issue. Mm-hmm. And so the reason why we care is this. Number 1, having regular periods is important to having a healthy uterine lining. And I know we've talked about this before. I've used this metaphor of the grass or the sod.
Yes, it's a good metaphor.
It makes sense to me. I talk about this all the time.
Yeah, it's a good metaphor.
That if you think about the lining of the uterus as grass or as sod, to have a healthy lining, you got to water it and you got to cut it, right?
Right.
And so estrogen is like water. It makes the lining of the uterus thick. Progesterone is like a lawnmower. It thins it out. And so you have, in a normal cycling healthy woman, you have this yin-yang balance, right, of the stimulative effect of estrogen and the suppressive effect of progesterone. Now, the way women who are in their reproductive years work kind of hormonally is that they're always producing estrogen. Always, always, always. So to varying degrees. But they only produce progesterone. This is fascinating. You got to love this stuff. You only produce progesterone if you release an egg or ovulate. And so if you don't ovulate on a regular basis, then you have less of the suppressive lawnmower effect of progesterone. So what I tell people is this. Just imagine that you've got a little elf in your uterus. Just imagine this, Twila. A little uterine elf.
This is usually where you lose me.
Yeah, a little uterine elf with a hose, spraying your uterus with estrogen every day, morning, night, spraying your uterus with estrogen to varying degrees. So it's stimulating that lining, just like if your little elf was watering your lawn every day, right? So, but what happens in polycystic ovarian syndrome is that you do not have the little progesterone elf with a lawnmower coming and mowing your lawn. And so what's supposed to happen is that you're watering the lawn, but then every 2 weeks the lawnmower comes out with a little elf and shaves it down, and then you have this perfect, beautiful lining. And so in PCOS, it's basically a situation where you're watering your lawn all the time and you're not cutting it. And what happens when you water but you don't cut, Twila Dang?
It overgrows.
You get a thick uterine lining.
See, I know things.
And so who cares? Who cares if you got a thick lining? Well, eventually you can get thick enough and start bleeding just because it's unstable.
Right.
But over time, and by that I mean years, decades, that imbalance between estrogen and progesterone can actually make you predisposed for cancer, pre-cancer, uterine cancer.
Mm-hmm.
And so that's why you got to pay attention. You got to inform your patients that if you have polycystic ovarian syndrome, you do not have regular periods, you are at risk for uterine cancer. So that's one thing we got to pay attention to.
Yeah, absolutely.
And so what else happens? Well, if you don't ovulate on a regular basis, if you don't have regular periods, it's also going to be more difficult to get pregnant, right?
Mm-hmm.
You know, ovaries are these, they produce eggs. The eggs are the targets. And, if you're ovulating once a month, and you're having intercourse at roughly the right time, and you're still reasonably young, 85% of the time you will get pregnant over the year, a normal healthy couple. Well, if you're only ovulating every 3 months, you're going to reduce your chance of getting pregnant.
Right.
And so, again, is that something that's life-threatening? No. But if you're a couple who's trying to build your family, that's a big deal.
Well, yeah, absolutely.
And so we need to pay attention to that. Now, one of the other fundamental issues with polycystic ovarian syndrome is that we believe that one of the fundamental abnormalities, which is genetic and somewhat lifestyle related, is there appears to be elevated levels of insulin in women with polycystic ovarian syndrome. Who cares? Who cares about insulin? Well, because that means that they need to produce more insulin to control their blood sugars.
Right.
And most of the time their blood sugars are normal, but the levels of insulin to do it are elevated. Well, those levels of insulin appear to be one of the fundamental issues that through a complex feedback loop end up creating the situation that elevates the testosterone.
Well, is that sort of extra impacted by the idea of having higher insulin? And then with the weight gain, does that make PCOS women who have it more susceptible to like diabetes and things like that?
Yes.
Okay.
Yes, little blossom.
I know.
Less
look at me.
Yes, grasshopper.
I know.
Elevated insulin, we live in a world of metabolic syndrome, right?
Right.
We are all, I'm not talking about you, but I'm going to include myself, we are heavier than we should be.
Oh, no, you can include me in there.
And so if you look at, obesity, adipose tissue creates more insulin.
Mm-hmm.
And so many of us are in a state of kind of pre-diabetes or insulin resistance anyway. And so women with PCOS, they may have elevated insulin levels, and this predisposes them over time to type 2 diabetes.
Okay.
And so, again, this is something that goes beyond cosmetics. It's not, we're not just talking about, nobody wants to have acne and abnormal hair growth. But acne and abnormal hair growth are probably not going to shorten your lifespan.
Yeah, absolutely.
Well, diabetes can. And women with PCOS, for reasons I don't know if anybody really understands, but they tend, not all of them, but they tend to gain weight easier than women who don't. And so, if you've got this condition, you're probably going to find that you put on weight much more easily than your friends who don't have PCOS. And then it's a feedback issue. The heavier you get, the more insulin resistant you
Right.
get. And over time, again, you're creating a situation that can lead you to pre-diabetes and finally even diabetes, which can have long-time repercussions.
Yeah, absolutely.
And so that's why we encourage people, and there's been studies to show this, is number one, to try to maintain your weight as best as possible, which we recommend for everybody. But also, these women tend to do a little bit better with low carbohydrate diets, which nobody likes.
Yeah.
But it really, if you can maintain a healthy lower carbohydrate diet, these women tend to do better. You also want to encourage them to just be active and at least try to maintain their weight. And one of the best things you can do in that is exercise, including weight training.
Okay.
Because
would you encourage weight training above other forms of exercise, or in addition to other forms of exercise?
In addition to other forms of exercise.
Okay.
So, everybody should be exercising.
Yes.
And that's a whole other show, right? I don't want to go farther. But as we get older, but I'm just saying that we might as well talk about it. We lose muscle mass, we lose flexibility, we lose cardiovascular function, and so we all want to be working on our cardiovascular system, doing aerobic stuff. But especially for people with PCOS, doing some weight training to increase muscle mass or maintain it is important because muscle burns more calories than fat.
Right.
So the issue with diabetes, there's also a increased risk of heart disease. Why is that? Well, because they have elevated testosterone. And so some women with severe polycystic ovarian syndrome can have elevated cholesterol, especially the bad stuff, LDL. And so these are things you just have to pay attention to. You're going to want to check those levels in people with polycystic ovarian syndrome more frequently than somebody who doesn't, and be on the alert for that.
Okay.
So again, this is the reason I wanted to talk about this, is that most people hear abnormal periods. Well, what's the big deal with that? If I don't have a period until every 6 months, that's great. Woohoo! That means I don't have to deal with my period.
Well, most women, have had some sort of experience with, an irregular period for like a myriad of other reasons, whether it be heavy physical activity or some other, illness, or using medication, going off of medication. There's all different kinds of things. So we tend not to think of that as necessarily a red flag, because it's really just a part of it's a hiccup or a bump in the road of a long road of menstruation. So we don't really focus on it.
Yeah, exactly. And so one of the reasons I just wanted to talk about this subject was to just, again, as we always try to do in the GynCast, just increase the level of understanding and awareness, because there are a few things we always keep banging away. For example, and what we talk about many times, pain with sex is not normal.
Right. Absolutely.
Severely painful periods, not normal. Well, having an abnormal menstrual cycle is not normal.
Right. Even if it seems like it's a gift.
Even if it's a gift. It's, unless you are working with a doctor and using, birth control pills or something like that to manipulate your period, it's not a good thing. And you need to get in and see your practitioner, your doctor, your midwife, whatever, for an evaluation. Because sometimes it can be other things, even aside from polycystic ovarian syndrome. There are other conditions that can cause abnormal periods that are important to know about too. And these have, all of them, but specifically polycystic ovarian syndrome, have potential severe repercussions on your long-term health. And that's why we got to know about it.
Absolutely.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
So how do we treat it? So we make the diagnosis. We talked about the diagnosis with the Rotterdam criteria. And boy, if you want to just take over a conversation, let's say it's Tuesday taco night at Twila Dang's house. Do you do that? Tuesday vegan taco nights with
No.
No. What is the yeast? Everybody, all you vegans use
seitan, tempeh.
Yeah. So you're making this awesome tacos, Tuesday tacos.
Yeah.
And you've got friends over, and the conversation dies, right? And you're sitting around, nobody, for whatever reason, I don't know why, you never seem like somebody would have trouble keeping a conversation.
That's not what happens at my house.
Let's just say that Twila has talked so much that she can't talk anymore.
That has happened.
And so everybody, all the other introverts around the table are sitting there looking at each other kind of. And then so somebody says, hey, have you been, how's everybody's periods here? Are they regular?
Yeah, because that's what happens at the table of my house. We just say, hey, how's your period? Is it regular?
I can tell Mr. Dang, I bet, would say that. Hey, let's just come down with it.
No, you do realize the second that sentence is uttered, at least a third of my table gets up and walks off, right? Any person at the table that has actual testicles gets up and leaves.
Oh, is that right?
And then we don't see them again.
Well, so I'm just, throwing out maybe not a good hypothetical here, but
maybe,
somebody can say.
Maybe amongst our girlfriends, because we are now of an age.
Yourselves.
We're of an age where, as women, when we are together, we talk about our maladies, because there are maladies and we just live with them. So,
exactly, and so, but there's always these. Let's just say it. They're dinks. Sometimes you're hanging out with, right? For some reason, you're in a meeting with somebody who's a guy who knows everything, or thinks they know everything, and you just start saying, I've been thinking quite a bit about the Rotterdam criteria. What do you think, Thomas? Silence. The guy will feel like an idiot. Well, this is important. So you just realize that. Think to yourself right now, if you're listening to this, do I have weird, wacky periods? And they've persisted for a while. And every woman is entitled to have a wacky period every once in a while, in my opinion.
Okay.
But if you have persistent, weird, and wacky periods, think, that's number one. Number two, do I have abnormal hair growth or acne? Well, again, if all the women in your family have, if you're from the Mediterranean or certain other areas where they tend to have a little bit more, hair growth just naturally.
Yeah, just naturally.
That may be less important. But if you're the only one in your family who's plucking and shaving, and at 5 o'clock you have some coarse hairs there, boom, number two. And if you have acne that even persists while you are an adult, you got to think about it. Boom. Okay, now you're thinking, I've got 2 criteria from the Rotterdam criteria. I meet the category for the diagnostic criteria for polycystic ovarian syndrome. I got to get in because I know now, after listening to the GynoCast, I may be at risk for uterine cancer over time. I may be at risk for diabetes and heart disease.
Is that
kaboom, Twila? Kaboom.
Indeed. I mean, I don't think I would say kaboom at the end of that sentence.
Kaboom.
But okay. I have a question though. Does this sort of fall under the category of things you've been a big advocate over time to say that you should know your history, and part of knowing your history is knowing your family history.
Yeah.
I would assume this falls squarely under something that women don't talk to other women about in their family if they even have a diagnosis like this, unless it impacts you directly.
Right.
I could see maybe you sharing it with your sister if if it turns out one of your siblings has it, but your mom might have it and never really discussed it with you.
That's right.
Or or your mother didn't have it, but your grandmother had it, or your aunt has it and you didn't know, and that there's actually possibly a closer tie. Would you advocate that this falls squarely under the sort of set of conversations that we're always encouraging people to have at the holidays and things like that?
Exactly. And this is one of these things that we are in a new world, Twila, where people will talk about everything.
Yes, they will.
And so you should talk about, as women, talk about your periods. find out what the family history is, because there's a genetic component to it, and there's a lifestyle component to it. So people who are at increased risk for polycystic ovarian syndrome are people, number one, where it runs in their family, and number two, who are heavier. So the heavier you are, there's a little bit more likely to have ovulatory issues. And so it's important to know that. And
now, I don't have a direct experience with PCOS, but I do have a direct experience with sort of being an advocate for talking amongst your family members. We've done this show in this format for a long time, and I have, over the course of time working with you, really learned a lot about women's bodies, about what is considered sort of normal behavior for your body and what's abnormal behavior for your body.
No.
And I've been really upfront with. I have a family member who for years has listened to the show and, asked questions on occasion. And, in the last couple of years have been suffering with a lot of pain and discomfort and other issues. And it sounded like things that I learned about here. So I had been sort of advocating like, hey, I'm not a doctor. I'm not a doctor, but I work with Dr. E, and we did ask him, and, I did get some advice. I think you should go see somebody. I think you should go ask these questions to your health provider. Yep. And it took a while, but she did ultimately got the courage to ask her health professional about it, got a referral to a specialist, was able to diagnose a very specific problem that she never knew she had, that had been suffering with to a degree for years, and is now on a much stronger path to recovery and feeling better.
Good.
Because she took the time to actually ask the question.
Yeah.
She'd been listening to the show. It took her like a year to work up the courage to ask me a question to ask you. So I think a lot of times we don't do this as women. We think we're supposed to suffer in silence. We think we're supposed to just suck it up and deal with it because that's how it is, when really there's actually something wrong. And you could find out, and you could possibly get, some, if nothing else, you get answers. You could possibly get some relief. You could possibly get some sort of long-term solution or maintenance or management.
That's right.
So there's absolutely no need to suffer if you can find an actual answer that can help you in your life.
That's right. And so, again, I'm glad you bring that up, because of the importance of self-advocacy and self-education, because I know I've said this before, it's horrible, but, doctors, practitioners are busy. And oftentimes, if people aren't comfortable bringing things up, we won't necessarily ask about it unless it fits into some particular area that we're looking at.
Right.
Like, for example, I just said, when somebody comes to see me for an infertility consult, I'm asking about that. Or with somebody who comes in with abnormal uterine bleeding, I'm asking about it. So I'm looking for it.
But that's based on who you are, your experience, and your sort of areas of expertise.
Well, and most gynecologists, when somebody comes in and they have weird and wacky periods, they're going to start asking some of those questions, and that's something that's pretty well on our radar all the time. But if you don't bring it up, and we're not looking for it, oftentimes we won't ask about it. And again, it's one of these things that, like many things, just can lead to issues.
So I feel like that's the eternal, like when you're having a conversation with somebody and you're at the end of the conversation and they go, so is there anything else?
Yeah, when they really don't want to know.
Right. And then you're like,
as they're standing up with their computer in the hand.
They've got the door open and you can feel the breeze up the back of the paper gown they've given you. You're like, no, I just want to put my clothes back on. Thanks.
Yeah.
Right. So I agree with you. I think that can be difficult. Yeah. That can be difficult to sort of get the courage up to say, I do have a question about this, or do you have a minute to talk to me about this? Yeah. I mean, I'm now a monster about it. Like I will be at the gynecologist's office and start asking all these other questions, and she'll be like, "Okay, so point of order, not a cardiologist.
Is that right?
You can't ask me about that, but I can refer to you to somebody great." She's like, "You're asking." Like now, I ask all the questions. I'm like, lab coat, stethoscope. I have questions for you. Let's get into it.
Well, you can take a swing at it. Well, I went to medical school.
But I love that. I think I'm proud of myself in that I've now gone to the far end. I went from being too mousy to ask anything to like, you got to know what this is, right?
I can't imagine you sitting there like a little, little flower.
But I'm talking about more in my youth. When you're in your early 20s and you're your late teens, your early 20s, and you're on your own for the first time, and a lot of times for women like that, your first real brush of healthcare is not like at your doctor's office with the doctor that grew up with you, you know, because heaven forbid the doctor who knows your mother knows this about you. It tends to be in your free clinic setting or your college clinic setting, which can be intimidating and odd as it is. And you don't know how to advocate for yourself, and you're kind of just trying to figure out how to be your own grown up. And that's incredibly intimidating you know, in most instances. So it does take a lot to get past sort of the initial, like, you know, you can do this. And to be honest, I would say for a lot of young women, their first real brush with healthcare to any extent is already wrapped up and fraught in all of the things that go around, like trying to advocate for your sexual health, but being mortified to ask some sort of stranger for help in that, whether it be birth control or whether it be like testing, or whether it be, you know, wanting to have the discussion about, you know, like what types of products to use, you know, and there's other health things on top of that that you can't, like, I can't even tell you how many women that I know whose first real experience with a doctor came after they started having sex, didn't have a lot of information at their disposal, only had like a UTI, which they were mortified about because they knew how they got it. And then they have to, you know, who's gonna ask the questions of the doctor when you're mortified and you just want to get your prescription and get out.
That's right.
You know, so I know how difficult that is, but I would say it's a muscle that you develop the more you use it. So even if the next time you're at your doctor's office and they just ask, is there anything else? And you just ask a random question, ask the random question.
Yeah.
You know why? Because now you've taken a brave step. You're learning how to, you're taking command of your own voice in that room, and that's tremendous, and it will help you in the long term.
That's right. And also, what is the downside? Number one, the doctor will or practitioner will say, okay, and sit down and we'll go over it. Or they'll say, you know what, that's a great question. It sounds like it's something you're concerned about. I really don't have time to address it now. Why don't you make an appointment where we can really sit down and talk about it?
Yeah. And I would say in sort of our changing climate of healthcare, that you're seeing a lot more sort of the deferred question, get you an answer, get back to you situation, which isn't bad to some degree, because if it can kind of take some of that sort of ancillary pressure off of asking an awkward or an uncomfortable question, where if you ask a doctor a question, they'll have the answer right away, and they say, hey, give me 24 hours to look into this and I'll give you a call back.
Yeah, right.
I actually think that takes some of the pressure off of you, you know, in terms of being able to get an answer to something that you might be curious about or you might be concerned about, and, you know, and help, you know, sort of put you on a path, and on a path that might not necessarily mean you go pay like another $25 copay and sit with another stranger. And, you know, like if you can start finding answers in a sort of almost like a bit of a detached environment, that can be helpful as well.
That's right. So let me cover quickly some of the options for treatment.
Yes.
Because if you've got it, you want to pay attention to some of the things that could have long-term repercussions. And so there are ways of dealing with all of these. So, for example, the abnormal hair growth and the acne, that's due to elevated levels of free testosterone in the blood. And so how do you manage that? Well, one of the first things that we do is, if there's no contraindications to it, is to put people on birth control pills. Birth control pills are fantastic for handling polycystic ovarian syndrome for two reasons. Number one, it gives you a regular period, and so it takes over that. It'll handle the issue of the menstrual irregularity. It'll make sure the lining doesn't get too thick.
Right.
And on top of that, birth control pills will, virtually all of them, decrease the level of free testosterone a little bit. And so over time, that's why most of us have heard that birth control pills can help with acne.
Yeah.
And so it can be a twofer. It can be one of these things that really manages a lot of the issues. And then what you would do is you'd keep these women on the birth control pill until they were interested in getting pregnant, for example. Take them off the pill, hopefully, and then just, you know, set them free. Go ahead and try to get pregnant as fast as you can.
Right.
And if we're lucky, you can get pregnant before the underlying metabolic issue starts coming back.
Oh, okay.
And so, and there's also medications, like there's a medication called spironolactone, which is actually a blood pressure medication, but it also works by decreasing free testosterone. Those are the big ones. There's some cosmetic creams. There's a cream called Vaniqua, which frankly I've never prescribed, and I'm not entirely sure if it's still there because it wasn't covered by insurance, and so most people weren't willing to pay for it. But there is I think that cream is still available. And for some people who the main issue is abnormal hair growth, laser hair removal.
Yeah,
can be a big deal.
and laser hair removal has changed so much in like the last 15 years. I mean, even like 15 years ago, it was really just an effective treatment if you were a very fair-skinned, specific type of skin type. But now, I mean, the playing field on laser hair removal is pretty level, all the way across the board.
Exactly.
And over time, the technology's improved, so the price point has come down significantly.
Yep.
I remember, entertaining it 15 years ago just out of vanity, and it was like, who's got $10,000 to drop on that? And that price point has dipped
it's really
significantly to be able to like do large areas of the body, very targeted areas of the body. The expertise level has gone up now as well. So that's
right.
absolutely an option.
So there's options for that. Again, the acne, certain obviously dermatologists can be helpful with that. But again, the same stuff. The birth control pills, spironolactone, can be very helpful with that.
Mm-hmm.
And so some of the other metabolic issues, the elevated cholesterol, we just got to know about that, number one, to treat it. And some of these things can be managed with lifestyle changes, increased exercise, as we talked about, trying to control weight or drop weight a little bit, and a lower carbohydrate diet. Sometimes people can really manage that. But for some people that may not be enough, and so they may need to have medication to try to help control that. And that's a big deal in terms of somebody's long-term health. Elevated levels of insulin and glucose. Well, so if somebody's pre-diabetic and sometimes even diabetic, and again, the lifestyle changes don't reverse that, there are medications that we use, especially one called metformin, which actually increases insulin sensitivity. And we can use that to drop insulin levels, glucose levels, and it is one of the things that we do sometimes to help treat infertility in these women. Because, and I've had success with this, is that sometimes women come in and for fertility issues, and we do the evaluation, we find out it looks like polycystic ovarian syndrome. One of the things sometimes we'll do is start them on this diabetic medication, metformin. And it can sometimes drop the insulin levels down, normalize their hormone levels to enough that they may start ovulating on their own. And sometimes they can get pregnant with simply that and not having to do anything more aggressive than that. And sometimes we use it even if they're not trying to get pregnant to try to normalize insulin levels, and that can, again, sometimes help reverse some of the metabolic imbalance, and they may start having regular periods, and so they may not need birth control pills and that sort of thing.
Okay.
And so the point is that there are things that can be done that are safe and effective. The most important thing is to know about it so that you can protect yourself and live a long and healthy life.
Indeed.
All right.
Well,
that's all I got to say.
Well, on that
I'm
note,
done here. Heegaard out.
Yeah, Heegaard out. On that note, we want to hear from you. We have a website. It's matriarchdm.com. There is a show page for the GynoCast. You can go there, listen to this episode, previous episodes of the show, and you can interact with us now. We have a lovely email address, hello@matriarchdm.com. You can email the show and let us know your thoughts, make suggestions. We have another suggestion for you. Go to Facebook. The GynoCast has a private group on Facebook. So if you go to Facebook and look up the GynoCast, request to be a member. It is a closed group, so we have to approve you to be a member of the group. But once you're a part of the group, we have all sorts of extended conversations about the topics of the show. We share information.
That's right.
People pose questions. We talk about a lot of things that we talk about on the show and difficult topics, but we do it in that space in a really supportive and respectful way. And I really appreciate that. And we will always do our best to keep that space exactly that, respectful and supportive.
That's right.
And hey, if you're so moved, we would love it if you would subscribe to the podcast. We would love it if you would rate it and review it as well. We would love your feedback.
Rate and review.
Indeed. We love what we're doing, and we love the opportunity to do this for you, and we'd like that to continue. So thank you so much for your support. We will talk to you soon.
Thank you, Twila. Thank you, listeners.